What are some of the studies so far that have been presented, or the materials that you've been reading, that you find the most compelling and the most promising, and the ones that will really impact your patients when you go back to practice?
So at a meeting like this, there are some very important presentations of very new and exciting drugs, often that we, even if we're running clinical trials, won't have access to for a number of months or years. But equally important for our day-to-day practice, and I'm going to have 12 or 14 breast cancer patients I'm going to see on Monday, are some of the fine-tuning that we hear about. So for instance, we've had a whole wealth of anti-estrogen, anti-hormonal therapies available to treat patients with advanced breast cancer. And we've never quite been able to figure out the exact order to use them in. And we think that many of them are equivalent and we can use them sequentially. And we had a very important study here that's really going to change our day-to-day practice in patients who come to us now with advanced breast cancer that's so-called hormone receptor positive. We have a big change in our normal algorithm on how we're going to treat these patients now. Typically those patients, last week we were giving aromatase inhibitors to, Arimidex, Femara, exemestane. We had a clinical trial presented that looked at using Faslodex fulvestrant, which is a drug that's given intramuscularly once a month. We had known about its effectiveness, I think the first presentation was at this meeting 8 to 9 years ago. We just found out within the last year that last year's meeting, that we were dosing it incorrectly. We found out a better schedule and a better dose. And
what was the dosing schedule?
It was a once-a-month dosing schedule, and they had known by studying the science and the pharmacology of it that the approved drug that we were using probably was not the optimal regimen. And at last year's meeting, doubling the dose and giving the first dose rather than monthly, the first and second dose, day 1 and day 15, 2 weeks later, and then going to monthly was better. So doubling the dose and increasing the frequency a small amount. So at this year's meeting, we have a study using the better schedule of the drug and comparing it first-line treatment to an aromatase inhibitor, anastrozole or Arimidex. And the results were kind of surprisingly striking. The time until the disease progressed was nearly twofold. No additional side effects. What we have to weigh the balance with our patients is taking a pill every day versus taking an intramuscular injection once a month. And I think with my patients, the preference would be just about split. I think there are certainly a number of patients that taking a monthly shot might be preferable to having to remember about the pills and taking the pills every day. What I think surprised me a little bit is they quickly ran over the side effect profile, and probably the most important Arimidex side effect that we hear about from patients is the muscle and joint aches and pains. At least the way they looked at it, they didn't see any difference, but certainly our experience in using the drugs is the expectation would that be much less by using the fulvestrant, the Faslodex. So a major change in our normal algorithm on treating advanced disease, just learning how to use the drug last year a little bit better, and now using this in quite slightly different sequencing.
So how do you handle the likely fallout or reaction of elevated anxiety for patients that may learn about a better delivery and dosing regimen, that may say, but I had it this way, that raises all the questions? Does that mean it wasn't ineffective? Does that mean it was useless? Does that mean my cancer is going to be worse now? All of the subsequent questions and the normal anxiety that's going to be a byproduct of new findings.
Good question, and that comes up. I usually I tell my patients that I'm also the head cheerleader in their case, and usually I can answer that with, well, you know, we're doing just fine now, and in fact the treatment you got may not be what we'd be choosing today, but still is a very, very good treatment that we have a very long track record of effectiveness and side effects, and we have some new information, and when we need to change treatments, we're going to have something we can do a little bit better.
You know, not necessarily you may not have to change people who are already on it, but you can start people when they're newly diagnosed. But I think the interesting thing about the oral therapy, you know, the compliance is horrendous. I mean, it's 50% of patients are not taking you have to take a pill for the rest of your life or until you progress. And you know when you take it, you're not going to be comfortable. It's going to hurt you and not. So, you know, what's the chance? Well, I forgot it, and guess what? I had a good day. Why did I have a good day? Because I forgot to take my Arimidex. You know, they catch up on very quickly that it's cause and effect. So I try to give them the vitamin D. I try to do all the other things to minimize the side effect. But the compliance is, and they get reminded that they have a disease. I said it's a chronic illness. You have to live with it. But it's a big deal. Now, the Fossildex, you know, the other thing, the problem is they're traveling. You know, for some patients, it may be an issue to travel once a month as opposed to come every 3 months.
Right.
You know, but I think in an average person that would not be an issue. You know, we knew about the dosing way back. We knew, and we used to kind of cheat it in a way, give it kind of towards the end of the month, and then start the first month or so. We kind of load it without really putting that we were loading because we knew it was an ineffective dose.
Ideally, the patients that are on the original dose, you will now want to change.
We already changed it. Yeah, I already done that. The data was already available.